Now, there is a case history of road traffic accident, and the lower limb was in an attitude of flexion, adduction, and internal rotation. Right? So I think most of you can very easily reach up to yes. Yeah, so this is Fadil, and the moment you see Fadil post-injury, that suggests posterior hip dislocation. Okay, so this is posterior hip dislocation. Okay, and if you look at the X-ray, what you will notice? What will be seen on the X-ray? Yes, lesser tubercle will not be well visualized, and classically this is the picture how a case of posterior hip dislocation will be seen. So this is how you will see. This is normal, this is injured, right? And we can see that the injured knee is almost crossing the normal knee. So this is adduction. Clear? So this is adduction here. And secondly, how you will say that there is internal rotation? You see the medial border of the foot. So this is the medial border of the foot, and it will be touching the couch. So adduction, internal rotation are quite evident. And thirdly, you can see the flexion as well. So this is flexion at the hip joint. So flexion, adduction, internal rotation. After injury, straightforward, you can say this is a case of posterior hip dislocation. So please make sure you don't do any sort of mistake in this. Now, fracture of which bone do not require any specific treatment. Any idea? See, for most of the fractures we do have some treatment plan. But for scapula, we don't worry too much. Clear? So for fractures of scapula, we don't worry because it is all surrounded by muscles. So it is all surrounded by muscles, and whenever a bone is surrounded by muscles, because muscles, what they will do? They will bring blood supply, and better the blood supply, more the blood supply, better the fracture healing. So therefore, if you see fracture femur, it is all surrounded by muscles. So a bone, if it is surrounded by muscles, it is presumed to have rich blood supply and therefore good union. So for fracture scapula, we don't worry too much, and we are very sure that after 7 to 10 days, it will start uniting. Then this question is very commonly asked. Fracture of humerus, which area
will not involve any nerve. So, can you make a guess? What can be the answer here? See, radial nerve can be injured if there is fracture through which part of humerus? Shaft of humerus. Very good. So if there is fracture through the shaft, and shaft is also known as diaphysis. Clear? So if there is through the fracture of the shaft or diaphysis, there is high possibility that the fracture fragments, they can poke through the radial nerve. And why we say so? Because suppose if this is the humerus, say this is medial, this is lateral, And what is the course of radial nerve? Radial nerve comes through the posterior cord, right? Travels behind the humerus. So it travels behind the humerus and then it comes to lie laterally. So if there is any fracture here, obviously it is going to injure the radial nerve. So this is the radial nerve. And this question has been asked almost every year. Then is there any possibility of ulnar nerve in any case or any fracture or fracture through any part of humerus? Yes, and that landmark is actually medial epicondyle, right? So medial epicondyle. So if there is a fracture through the medial epicondyle, it can injure median nerve. Clear? So if you look at the anatomy, the lower part of say humerus is somewhat like this. So the radial nerve, the median nerve, sorry, it passes like this. Okay. So it passes like this, like this. So this is the median nerve, ulnar nerve, and it is passing behind the medial epicondyle. So if there is any fracture in this area, any fracture here, it will injure ulnar nerve. Median nerve, any possibility of injury to median nerve? Yes, there is possibility, especially through the fracture supracondylar humerus. Fracture supracondylar humerus. And which area is the
Veggie cook program. And they will bring the veggie and stuff.
So you see, humerus is such an important bone. At different locations, there are different nerves which comes into the vicinity or relation. And whenever there is a fracture, the sharp bony margins, they can puncture into the nerve. Not only this is important from exam point of view, this is also important from clinical practice point of view. And why we teach this? Actually because sometimes what happens when the patient has come to the emergency and if you don't notice it, next morning the patient will say that Dr. this is just because of you. You applied cast or if you do surgery, then he will blame you for that. So always and always whenever you see a case, it is your duty to check for any nerve or vessel injury and document it at the time of admission only. Then you will be safe. Otherwise there will be a consumer and then 4 or 5 lakhs. It's very difficult to defend. So that's why it's very important. Okay? So if someone asks you to read one bone, my answer will be please read humerus. Because you see 4 nerves, they are in close proximity. So very important from clinical practice point of view. So answer here is musculocutaneous nerve. It is not documented to be injured in case of fracture of humerus. So you see this is an image which shows the different nerves. You can see the axillary nerve winding around the surgical neck. Okay, so this is winding around the surgical neck. You can see the median nerve which is passing anterior. This is the median nerve going like this from the cubital fossa. This all area is the supracondylar area. So if there is a fracture in this area, there is high possibility that it will injure median nerve, or more specifically it's one branch, that is the anterior dorsal. And you can see the ulnar nerve passing behind the medial element. And lastly and more importantly, radial nerve, which is coming from the posterior cord. This is the radial nerve coming out like this, traveling behind that. So please remember, this is supracondylar fracture. This is medial condylar fracture, and this is fracture of please remember this one. Then what is this? A 3-year-old child has a history of fall from height, and you X-ray, there was no bone injury, you let the patient go, and after 2 years when the child came back to you, he was having deformity. So what is the probable cause for this? Any idea? 3-year-old child.
Okay, so can you think what could be the reason here why a child who was looking normal at the time of injury now after 2 years coming with a deformity? Any idea? Actually, what happens for this, you should know the anatomy of the long bone of a child. When we discuss the anatomy of a long bone, the middle part is known as, what is the middle part? Shaft. Very good. And what is another term for shaft? Shaft is also known as diaphysis. Clear? So this is shaft, also known as diaphysis. After shaft there is an expanded portion. And what is this expanded portion? Yes, what is the expanded portion? Metaphysis. Then finally the articular ends are known as epiphysis. Okay, this is epiphysis. Now this is for adult. If we talk about a child, then there is an intervening physis. Clear? So this is for children. Epiphysis, physis, metaphysis, diaphysis. Now what is the role of this physis? Why it is important in childhood? Any idea? Why it is so important? Because it is responsible for longitudinal growth. Very good. It is responsible for longitudinal growth. So we see that, say at the age of 3 years, bones are this much. At the age of 6 years, bones are this much. So what is that factor which is increasing the length of bone? That is physis. Now what happens? Sometimes whenever there is a fall from height, there can be injury to physis. And what is that classification system for physeal injuries? That is Salter-Harris classification. So this is Salter-Harris classification for epiphyseal injuries or childhood injuries, because in children's this physis is an additional area and at times it is the real problem. So what happens? How we can take the 5 types of injury from the mnemonic, we can make the mnemonic from the name itself. Okay, so S is for separation. S means separation. So what will happen? Suppose if this is the bone, the physis will go like this. Clear? So this is separation. So there is no fracture line, only the epiphysis has moved away from the metaphysis. This is metaphysis, this is epiphysis. So you can see there is separation. Number 2, A. A means above. Now what is above? Above physis, and it is only at a later date when there is no longitudinal growth, patient will develop either deformity or the limb will shorten. So probably this has happened in this case. There was unequal physeal injury and therefore there is calcaneal valgus. Now what do you mean by the word calcaneal valgus? Suppose if this is the right foot, it means the foot will turn like this. So if we take the X-ray, calcaneal valgus means the foot will turn like this. Okay, so the sole will go outside, and this is only possible if there is erasure on this side and this side is all normal. So this is normal. So what will happen? The normal side will keep on growing and the foot will keep on becoming bent and bent. So this will lead to calcaneal valgus deformity. So answer will be compression of only the lateral half of tibia. If there is complete involvement, it will not grow and it will be short as compared to the other side, because other side will continue to grow in length, but here if it is complete it will stop growing in length and therefore the affected limb will be smaller as compared to the other side. So a very beautiful concept, and that's why physeal injuries are very important in clinical practice, because if you don't know the concept of physis you might miss them. Chalo, next question. If a fracture is taking more time for union, what you will call this? See, fracture union problems. Process, and you can write like here time. So if the process is going on but taking more time as what is being asked in the question, what is this condition? This is known as delayed union. What is this known as? Delayed union. Clear? Process is going on but it is taking more time, so it is delayed. Sometimes what happens? Process is not going on at all. So what will happen? This is non-union, right? If the process has stopped before the union of the bone, you will call it non-union. So process has stopped and union has not occurred. This is non-union. Sometimes process has been completed but in a wrong position. So if deformity is present, what you will call this? Malunion. Very good. So the bone has joined but in a wrong position, that is malunion. If there is no process of union and the fragments are moving up and down, this is non-union. If there is no movement, process is going on but is taking more than usual time, like suppose we say 3 to 4 months, it is taking 7 to 8 months, then that is delayed union. So delayed means taking more time, non-union means process is not going at all, malunion means joint, as the fracture area has joined, now it is in wrong position. Now sometimes what happens, they may ask you examples. Like for malunion, you should remember few areas where malunion is commonly seen. So one of the commonest bone is clavicle. So clavicle will fracture and most of the time it joins in somewhat wrong position. But for us it is not a matter of concern, because the function of clavicle is to transmit the weight of upper limb. So whether it joins nicely or up and down, it is doing its function, right? So we don't bother. Another fracture which can go into malunion is Colles fracture. Distal and radius. And third fracture which usually goes in malunion is fracture intertrochanter of the proximal femur. Clear? So these are few conditions where you should know malunion. Is this screen okay? Can we turn it to slightly to the left side? Perfect. Right? So malunion means the bone has joined but in a wrong position. Now can you tell me any two examples where fracture has a high possibility of going into non-union? And now this is very important, because whenever you see such a case, it should be in your mind that this fracture can complicate into non-union. So one is fracture neck of femur. Okay, that is very important. It can go into non-union. Right? So this is very important. So these are union problems. Now, what is the principle of the surgical process shown below? So firstly, you have to identify the surgery. Which surgery is shown in the image? This is tension band wiring. So what is this? Tension band wiring. Because you can see this is one K wire. Okay. So this is one K wire going like this. This is the another K wire going like this. Okay. And this is stainless steel wire looking like a figure of 8. So this surgery is, this is K wire. So this surgery is TBW, tension band wiring. Now which it is for which fracture? This is actually patella. Right? So what happens actually, why we do it in patella? There is one more example, that is olecranon process. So here what happens, whenever the muscles, if they try to take the fragments apart, because of this assembly, fragments will indirectly come closure. Right? So it means distractive forces are converted into compressive forces. So the forces which were trying to take the fragments apart will ultimately bring them closure, and the fragments will compress against each other, and this is one of the conditions required for good union. So this is the principle of TBW. Remember two conditions: fracture patella, fracture olecranon process. Okay. A patient presented to the OPD with complaints of pain, swelling in the left shoulder joint following a fall on outstretched hand. So this is FOOSH. This is known as FOOSH. Fall on outstretched hand. The X-ray is shown. What is the most common complication of this fracture? Yes, which fracture you can see in the given X-ray? Which bone is this? Very good. So you can see there is fracture of clavicle, and classically we can see this is lateral and this is medial. Very good. So the fracture is acting at a junction of medial, very good, and lateral 1/3. So junction is medial to the lateral 1/3. And what is the most common complication? I already told you, is possibility of anterior shoulder dislocation. And since patient knows this, that the moment my shoulder goes into abduction external rotation, it can dislocate it. So the patient will tell the doctor to stop the process or stop the maneuver, and this is known as apprehension test. Now, what do you mean by apprehension test? Patient is fearful. So the moment you do abduction, axial rotation, he will think that now my joint will get dislocated, so we'll stop the doctor. So this test is done for which condition? Recurrent shoulder dislocation. Recurrent shoulder dislocation. Is that clear? Chalo, next question. A 65 years post-menopausal woman had a history of fall on floor over fush, and there was a bony fracture around the wrist. What fracture you think might have occurred? So this is a fush injury, fall on outstretched hand. So this is what we can see here. So fall over, yes. So which fracture you can think of in a lady 65 years post-menopausal? Around wrist. This is Colles. Which fracture? Colles fracture. Clear? So this is Colles fracture. So here you can see the Colles fracture with a classical dinner fork deformity. So this is the dinner fork deformity, and this is because of distal displacement of this fragment, which is actually the distal fragment. So dorsal displacement of distal fragment. Dorsal means it is going backward. So dorsal displacement, distal fragment. Now this is dinner fork deformity. There is one term, this is dinner fork. There is one term known as garden spade deformity. What is that? Garden spade. Yes. This is seen in reverse Colles, which is also known as Smith's fracture. Right? So reverse Colles, because the distal fragment comes volarly. In Colles, the distal fragment goes posteriorly. Okay? So this is dinner fork garden spade deformity. Yes, look at this question. What can be the answer here? Dashboard injury. Very good. It is posterior dislocation of hip. Very good. And look at this image. It will tell you why we call it dashboard injury. You understand the mechanism? Okay, so we can see here the knee is striking the dashboard. So knee will become stationary here, but a back force will be generated along the shaft of femur, and it will take the head of femur out of the acetabulum. So this is dashboard injury, right? So dashboard injury is what? Which type of dislocation? Very good. So this is posterior hip dislocation. Sometimes it can also injure the knee joint. Now TB hip joint. There are 3 stages. One of the stage is synovitis. So one of the stage is synovitis. Now what happens in synovitis? There is inflammation of synovium, and whenever there is inflammation of synovium, what is the function of synovium? Increased synovial fluid, but the synovial fluid is contained within the capsule, so the joint will assume a position in which the capacity of the capsule is maximum, and that position is Faber. That position is Faber. Right? Flexion, abduction, external rotation. Now when if someone keeps the lower limb in this position, it looks as if the lower limb is lengthened. The length of the 2 sides, you cannot say whether it is stage 2, that is early arthritis, or it is stage 3, that is late arthritis. So this is how clinically we differentiate. So the question here is very straightforward, but in real process the questions are extremely difficult, but yes, you can, if you know the point, you can answer it easily. Okay, just 5 minutes break and then we will continue. Till that moment you can study the question number 12, and I think most of you must be able to answer that. बहुत ठंडा हो जाता है, इसमें थोड़ा सा मिक्स कर दूं मैं, ज़्यादा गर्म है क्या? Okay, so can we start? So now for question 12, what will be your answer? See, there is pain in the right hip joint, right? There is a past history of night cries. It means the patient used to cry at night, and then there was true shortening of the lower limb. The moment you have the word true shortening, which stage you can think of? Very good. Advanced arthritis. Because remember, a limb can only become short, it can never lengthen. And shortening will be true if it is actually causing damage to the length of the bone. So, in advanced arthritis, there is damage to the head of femur, and therefore the total length will decrease. So, this is advanced arthritis. Now, here we are getting one word, night cries. What does this mean? Actually, what happens in the daytime, whenever there is inflammation, the surrounding muscles, they become stiff. They go into spasm, and therefore patient will not walk freely. And this spasm is just to make sure that there is no rubbing of bony ends, because that is very painful. But what happens during night? The muscles relax, and the moment patient takes the turn, the bony ends will rub against each other, and that will produce very severe pain. So maybe around 2 a.m. or 3 a.m. the patient will start crying and he will wake up. So that is just because muscle relaxation, and if we turn to one side, other side, there will be movement, and that is extremely painful. Anyway, true shortening in a suspected case of TB hip, always and always late arthritis. Fine. So very easy to diagnose, and yes, very important. Most of the time we have question. Now in advanced arthritis, you should remember two terms which are very frequently asked. One is mortar and pestle appearance. What is this? Mortar and pestle appearance. Any idea what is this mortar and pestle? If you have seen with those Ayurvedic doctors, they have one, device to crush the medicines. Yes, so mortar and pestle. And another is wandering acetabulum. So just remember two terms: wandering acetabulum and mortar and pestle appearance in advanced arthritis. Clear? So this is classically case of TB hip. So this is a case of TB hip. Then pain and tenderness over lateral condyle of humerus on passive dorsiflexion of the wrist. What is this condition? And if you can see, this is the test which is being shown. The wrist is dorsiflexed like this, and the patient will complain of very severe pain at the lateral epicondyle. Now, this particular test is known as Finkelstein test. Clear? So this is Finkelstein test, and this is done for which condition? Sorry, not Finkelstein, Cozen test. This is done for which condition? What is tennis elbow? I'm sorry. What is tennis elbow? Lateral epicondylitis. Lateral epicondylitis. And what muscles they originate from lateral epicondyle? All the muscles of the extensor compartment of forearm. So what happens when we stretch the extensor muscles? The point of origin will it will generate pain at the point of origin. So this is known as tennis elbow or inflammation of the lateral epicondyle. So you can call it lateral epicondylitis. Clear? So another term is lateral epicondylitis. Okay. So this is Cozen test, and what we need to do? We need to put a tennis elbow band somewhere here. So this is the position of the tennis elbow band, because we don't want the stretch to reach up to the lateral epicondyle. Because many people, they put the band here, but this is the wrong position. It should not be put here. It should be put on the upper part of forearm. Now Trethovan's sign. Any idea what is Trethovan's sign? Where it is seen? Now look here. What is this structure which I have drawn with yellow color? In a child, we don't call it head of femur, right? In a child, we don't call it head of femur. In a child, it's better you call it femoral. For head, what we use? Capital. So femoral capital epiphysis. Femoral capital epiphysis, right? So this yellow area is all femoral capital epiphysis. And what we see, if we draw a line along the upper part or the upper border of neck of femur, it should pass through the substance of femoral capital epiphysis. But look on this side, what has happened? What has happened on the other side? The line which was drawn along the upper border of the neck of femur passes above the femoral capital epiphysis. So it means the femoral capital epiphysis has slipped. It has moved down, therefore the line is passing above that. So what is this condition called? Slipped capital femoral epiphysis. So this is SCFE. Clear? So this is very important. So this is Tretovan sign. So next question. A 5-year-old child presented with knee pain, irritability and gum bleeding. Radiograph is shown below. What is your diagnosis? There is knee pain, irritability and gum bleeding. Gum bleeding, what condition? Scurvy. Classical word, right? Defective synthesis of collagen. So this is scurvy. And on X-ray, what you can see here? You can see a spur here. So this is known as Falcon spur. So what is that? Falcon spur. Then we can see white all around. So what is this white line? Very good. White line of Frankel. And then you can see black area. This is Trummerfeld zone. So T is Trummerfeld zone. Apart from this, what you can see? This is Wimberger ring sign. What is this? Wimberger ring sign. You can see pencil thin cortex. So this is classical picture for scurvy. And in case history, the confirmatory word is gum bleeding. So in a rickets, there is gum bleeding. Now what is true for vitamin D deficiency rickets? What is true for vitamin D deficiency rickets? Calcium will be high or low? Rickets na, rickets में calcium is low. Then vitamin D high or low? It is also low. And when there is low calcium, which hormone becomes high? parathormone. So answer here is yes, B. Calcium low, PTH high, vitamin D3 low. Right? So this is vitamin D3. Okay, so this is how you will answer this question. Chalo, next question. A woman presented to ortho OPD with pain in knee joints. Right? She is obese. There is a sound of click whenever she is going up and down. Then pain aggravates on going up or down the stairs. This is the X-ray. What is your diagnosis here? So you look at the joint space. This is the joint space here and this is the joint space here. So on this side the joint space is reduced. And joint space can be understood by the black area. And this reduced joint space in an obese woman, then click, and especially pain coming on exertion, this is very suggestive of which condition? Osteoarthritis. Clear? So this is osteoarthritis, a condition seen in overweight people, elderly people, and this is the medial compartment of knee joint. This is the lateral compartment. So in medium side you can see there is no space. Femur and tibia, they has come close together. And here this is actually varus deformity, showing opening of the lateral space in the knee joint. So classical osteoarthritis. Next question. An elderly patient underwent THR, is now having breathlessness. What is diagnosis? So here we can see this is an elderly patient undergone long duration surgery, now is having breathlessness. So it means there is DVT which can result into pulmonary thromboembolism. Right? So breathlessness suggests there is thromboembolism, and it is secondary to DVT, which is seen in elderly people who had underwent long duration surgeries like THR. A person who is taking non-veg diet has pain, redness in the grade 2. So redness, pain in the grade 2. Then he has similar episodes in the past. It means the same problem is repeating again and again. Uric acid is also high. Which drug you will give in such a case? Yes, any idea? Yes, very good. This is a case of gout. Very right. Yes. And why allopurinol, not NSAIDs? Because this is chronic gout. Right? Why chronic gout? Because same episodes has happened before also. So this is chronic gout, and for chronic gout we should give allopurinol. Allopurinol should not be given to acute cases. It is only reserved for chronic cases. So here you can see the classical presentation. The moment you see swelling, redness, pain, tenderness in grade 2 region, especially first metatarsophalangeal, straight away go to make an answer of gout, and here we should give allopurinol, a xanthine oxidase inhibitor. Chalo, next question. Alcoholic patient has slept keeping her head over her arm. Next morning he found that his radial nerve is gone. This is which kind of injury? Now here what is the mechanism of injury? There is compression. Compression can lead to some disturbance in the conduction. So this is neurapraxia. What is this? Neurapraxia. And it means there is physiological disturbance and not anatomical disturbance. So this is neurapraxia, and here what is the prognosis? 100% recovery. So tell the patient, don't worry, you will be alright shortly. So the neurapraxia. So in neuropraxia, anatomy is normal, only physiology disturbed. In axonotmesis, the axons are cut. So this is axonotmesis. Axons are cut. And if the whole nerve is cut, you will call it neurotmesis. So you can see here the whole nerve is cut into two parts, and therefore the prognosis of spontaneous recovery is very bad here. Right? So these are the three types of injuries. Then a lady presented with tingling sensations in thumb finger, index finger and middle finger. Then this problem can be aggravated by palmar flexing the wrist for 1 minute. What is your diagnosis? The moment you have these three fingers involvement, thumb, index finger, middle finger and half of ring finger, 3.5 lateral, which nerve territory is this? Median nerve. Very good. So this is median nerve territory. And if there are compression neuropathy signs of median nerve, usually the condition is carpal tunnel syndrome. And we can aggravate this compression further by doing palmar flexion of wrist for around 1 minute, and patient will say that my complaints are getting more and more severe. So this is carpal tunnel syndrome, compression neuropathy of median nerve, carpal tunnel syndrome. Right? So very common question, and the only thing which you need to remember is 3.5. So 1, 2, 3.5. Okay? So this is the demarcation point. Fine? Chalo. Next question. Eccentric epiphyseal tumor which can go into a metaphysis in a patient of 25 years. 25 years from epiphysis going till metaphysis, and remember word eccentric. Eccentric means most towards one side. So what tumor you can think of? This is giant cell tumor, and here we can see one more important finding, and that is soap bubble appearance. Very good. Okay. So classically what you will see? Like this, soap bubble appearance. Okay. This is giant cell tumor. So even that is sufficient to make an answer of anterior hip dislocation. Clear? So this is how, and these are special topics from orthopedics from which the questions are usually repeated, right? So today I'll take only this much. Okay, fine. This is one good image. So what we do, we draw a line from the middle and see this limb is so far, this limb is also far. So both are abducted. And look at the lateral border of the foot. The lateral border is almost touching the couch. Look at the position of the toes. Right? So this is a classical external rotation deformity. So abduction, external rotation, what you will say? Anterior dislocation. And look at the lesser trochanter. Lesser trochanter is prominent. What dislocation is this then? Anterior. So this is the head of femur lying outside the acetabulum, and classically this is the anterior hip dislocation. Okay. So today I am taking only this much, and tomorrow we will meet at 9, and tomorrow I am planning to take 7 subjects, right? So I'll share the schedule with all of you, like what subjects I'll be taking. So see you tomorrow 9 a.m. Huh? Chalo. Okay, and I'll share this annotated PDF. And if there are any suggestions, you can just share. Anything which you want me to modify, or it's okay.